Hello, my name is Rajeev Attam. On behalf of all my co-authors, I wish to thank GIE for this wonderful opportunity to present a work titled Wet Suction Technique, or WEST, a novel way to enhance the quality of EUS-FNA aspirate, results of a prospective, single-blind randomized controlled trial using a 22-gauge needle for EUS-FNA of solid lesions. EUS-guided FNA is now being routinely used to sample various lesions involving the pancreas, liver, gastric wall, adrenal glands, kidney, as well as lymph nodes in the areas adjacent to the GI tract. Currently, multiple needle types and aspiration techniques are in use without a clear consensus on the optimal aspiration technique. Most techniques involve use of varying degrees of suction with or without the use of a stylet. We describe a novel technique which involves flushing the needle with 5 cc of saline to replace a column of air within the lumen of needle with saline prior to needle aspiration. The technique was developed with an aim to improve the quality of aspirates for cytopathological diagnosis. We have named it the wet suction technique, or WEST. Let me briefly tell you about the origins of this technique. While performing EUS-FNA, we did not usually employ a stylet, and hence we would flush the needle after each pass to remove any tissue or debris stuck within the needle. While doing so, we realized that the quality of tissue aspirate was better after the needle had been flushed with saline. We then thought of leaving a column of saline within the needle to replace a column of air. We again saw a marked difference in the quality of aspirate as assessed by on-site cytopathologists. Not only the aspirate was more cellular, but was less bloody. To test the technique against the standard EUS-FNA techniques, we performed a small pilot study at the institution. The study confirmed our initial findings and showed improved specimen adequacy and cellularity. We then embarked on a single-blind randomized multi-center controlled trial to compare this novel technique to conventional FNA technique. The study was performed using a 22-gauge needle using identical suction in both groups. All consecutive patients, 18 years and older, referred for EUS-FNA of solid lesions to the 2 participating centers, University of Minnesota Medical Center, Minneapolis, and Aurora St. Luke's Medical Center, Milwaukee, Wisconsin, from January of 2013 to November of 2013 were offered participation in the study. The trial was registered in clinicaltrials.gov in October 25 of 2012. Patients with coagulopathy, cystic, and solid cystic lesions were excluded. To remove any bias, all study lesions were sampled using both the conventional and the wet suction technique in alternating manner with the same EUS-FNA needle. The sequence of conventional versus wet suction was determined by unrestricted randomization. If the first pass was performed using wet suction technique, then the second pass was performed using conventional technique, the third again with wet, and fourth with conventional technique, and so on. Conversely, if the first pass was made using conventional technique, the second pass was made using wet suction technique, third with conventional, and fourth with wet suction technique, and so on. The cytopathologists and the technicians present in the room were blinded to the aspiration technique. For wet suction technique, after removing the stylet, the needle was flushed with 5 cc of saline to replace a column of air with saline. A 10 cc suction syringe loaded to maximal suction was attached in locked position to the needle after flushing the needle with saline. For conventional technique, the stylet was removed from the needle prior to performing EUS-FNA. A 10 cc syringe loaded to maximal suction was again attached to the needle. Suction was applied once the lesion was punctured. The primary outcome was defined as the adequacy of the specimen obtained by EUS-FNA for each aspiration technique. A specimen was defined as adequate if it had sufficient material for the cytopathologist to reach a cytopathological diagnosis. The secondary outcomes included the degree of cellularity of aspirate and blood contamination of the specimen obtained by the 2 techniques. At University of Minnesota, where an on-site cytopathologist was present, a drop of expressed aspirate was placed on a slide and 2 smears were first made. The remainder of the aspirate was sent in 2 formalin bottles, one for each type of aspiration technique labeled as A or B, for cell block analysis. The on-site cytopathologists and technicians were blinded to the aspiration technique. At Aurora Medical Center, Wisconsin, all the aspirates were expressed straight into the separate formalin containers, one for each aspiration technique type, and were labeled as A or B and sent for cell block analysis. No slides were prepared for immediate on-site interpretation at Aurora Medical Center. All the cell blocks specimen were then evaluated by the study cytopathologist, who was blinded to the type of FNA technique used. Specimen were assessed for being adequate to reach a diagnosis. Cellularity was graded on a numerical scale from 0 to 3, with 0 being acellular and 3 being highly cellular. Bloodiness of the aspirate was also graded on a numerical scale of 0 to 2. A total of 117 lesions sampled, and their cell block was later evaluated by the study pathologist. The most commonly sampled lesion in our study group was pancreas, followed by lymph nodes. Wet suction technique cell block resulted in a significantly better specimen adequacy of 85.5% versus 75.2% with conventional technique. Cellularity of cell block was graded on a linear scale of 0 to 3. Wet suction technique provided an aspirate specimen with a higher mean cellularity score of 1.82 as compared to 1.45 with conventional technique. This was statistically significant. A larger portion of aspirates with wet suction technique were read as moderate and high cellularity as compared to conventional technique. On the other hand, acellular and poorly cellular specimens were more frequent with conventional techniques. There was no difference in the amount of blood contamination between the two techniques. Although we do not know the exact mechanism by which the wet suction technique resulted in improved cellularity and diagnostic yield, there are several possible reasons to explain this. Firstly, a column of saline may allow for better transmission of applied suction as compared to a column of air within the needle hollow. Second, saline may coat the inner lining of the needle and thereby change surface properties, leading to easier movement of aspirate into the needle. And thirdly, the column of saline may act as a stylet, thereby potentially reducing the contamination from GI tissue during the needle puncture into lesion and keeping the needle unclogged. The wet suction technique has several potential benefits. The technique involves minimal modifications to the conventional aspiration technique and can therefore be performed easily and without any significant additional cost. In addition, the act of flushing saline through the needle after each pass does not add any significant amount of time and may actually have the benefit of ensuring that the entire aspirate is expressed into the formalin jar rather than the tissue being left behind in the needle lumen. The wet suction technique also does not involve the use of a stylet during tissue acquisition, which many find cumbersome and time-consuming. This is the first study involving a new technique, and even though the preliminary results are very promising, further multicenter studies are warranted before a widespread change in EUS-FNA practice is advocated. Further areas of study include the performance characteristics of wet suction technique using different needle sizes and effective wet suction technique on diagnostic yield of both on-site cytology and cell block specimen. I thank you for your attention.